Hi, everyone. I'm happy to be here with you today. And I am going to be the moderator for this panel. And the panel will focus on disparities in cancer prevention. And we know that disparities exist in exposures and prevention programming and even access to healthcare and services, as some of our previous speakers have alluded to. And the work of the 4 dedicated professionals that I'm going to ask to come forward in a second highlights the critical issues in all of these areas, and we are so honored to have them with us today. So, without further ado, I would like to ask Stanley to come forward, and also Dr. Tom Uldrick. Thank you. Dr. Kelly Hirko. And Sana Chehimi. So each of the panelists is doing really interesting and varied work in terms of disparities associated with cancer. And they've provided me with some questions and I guess I should say kind of cheater notes so that I can ask them some informed questions. So I'm going to do that one at a time. And we are going to start with Stanley. And let me tell you a little bit about She is the Communications and Marketing Manager at Traverse Health Clinic. She holds an Associates of Arts degree from Northwestern Michigan College and a Bachelor of Arts from Michigan State University and a Master of Fine Arts from Syracuse.
Well, thank you so much for inviting us to be part of this very important event today. So Traverse City, for the way that I usually introduce Northeasterners to the area that where our clinic is located, is kind of like a Cape Cod on freshwater. So it's a fairly affluent, really beautiful area that has still has some poverty underlying and issues of access that we, as a FQHC, Federally Qualified Health Center, work very hard to address.
Okay, great. Can you tell us what some of the specific health disparities are that your patient population experiences?
Sure. So as an FQHC, we are located in an area that's designated as medically underserved. And the very specific neighborhood where we're located, the median income is about $38,000 a year. So, and about half of the housing stock there, if for the people who own homes, has a value of less than $100,000. So we're talking about an area that has very disproportionate level of poverty relative to an affluent region. And across the country, 1 in 3 people who live in poverty are served by a federally qualified health center. And so what we're looking at in terms of how we are in Michigan has been one of the states that expanded Medicaid, and that has been a huge benefit to getting access to care. And our health center provides integrated primary care and behavioral health, and that's accessible to anyone. So everyone is welcome, whether you have private insurance or Medicaid or no insurance at all. No one is ever turned away because of an inability to pay. And so what's really important to us, though, is it's not just giving access to healthcare, it's access to high quality healthcare. So some of the things that we're particularly proud of are, for instance, our cervical cancer screening rates. So nationwide, it's about 56% of women are getting their cervical cancer screenings as recommended. For our patients at our clinic, that's almost 71%. So that's huge. We also, in terms of obesity, for adults being screened for their obesity and then follow up with counseling about nutrition and healthy activities. Nationwide, it's about 70% of patients who get that, and it's about 82% of our patients. So these are some of those risk factors that we know are modifiable with behaviors, and we really try to put our providers are all very interested in putting the patient in charge of their health, their care plan. If someone has a diagnosis of depression when they're in with their primary care provider, they can get a warm handoff to a counselor or therapist who's just down the hall. And 90% of the patients we serve are at or below 200% of the federal poverty level, which means these are working poor people who are really struggling to make ends meet. Over half of our patients are below the poverty level. So this really is, we have about 3,800 people that we serve every year, and they are people who would probably go without access to care if we didn't exist.
Oh, my goodness. Thank you for giving us just a snapshot of the incredible work you're doing. It's one thing to talk about providing access, but it's a whole nother thing to actually provide access to high quality care. So bless you for that amazing work. We thank you. Next, I'd like to turn to Dr. Uldrick, and I'll tell you a little bit about him. He is the Deputy Head of Global Oncology, the Fred Hutchinson Cancer Research Center. He is the Deputy Program, I already said that, I'm sorry. He's also Associate Professor of Medicine at the University of Washington, Division of Medical Oncology. He is a principal investigator and a member of the Steering Committee of Cancer Immunotherapy Trials Network. His major research interests are the pathogenesis and management of virus-associated cancers, including those that occur in the setting of HIV. So, with that introduction, I was wondering if you could tell us a little bit about the work you're doing, particularly with the ANCHOR study, and maybe even then discuss a little bit about the risk for anal cancer and cervical cancer and breast cancer associated with HIV.
Great, thank you. Is this on? Thank you for the introduction. So, just as a way of background, my work, I'm a medical oncologist. I trained in treating people with cancer, but also trained in cancer epidemiology. And for the past decade or so, have been really focused on viruses that cause cancer. And so I think it's important to think of this in the context of array of viruses that cause cancer. About 1 in 6 cancers globally is caused by an infectious disease. And this is my third year at this event. And really the reason talking about it is so important is many infection-related cancers are probably preventable. We know that there are several viruses, including HPV, which causes anal cancer and cervical cancer, which I'll get back to in just a second to answer your question, that cause various types of cancers, including head and neck cancer, cervical cancer, and anal cancer, hepatitis B virus, which causes liver cancer, Epstein-Barr virus, which is a virus that was discovered in Uganda, which causes lymphoma, and a similar virus called Kaposi sarcoma herpes virus, which was first discovered in AIDS patients in the 1990s in the US. HIV is an interesting virus. All the other viruses I talked about are directly found in cancer cells. HIV increases the risk of a range of cancers by not directly, but by affecting our immune system and our immune system's ability to control cancer. And so there's a lot of prevention that can be done just around HIV. When you look at cancers that occur in the setting of HIV, there are about 8 that predominate, and those include Kaposi sarcoma, lymphoma, cervical cancer, anal cancer. These are all caused by viruses, as well as smoking-related cancers, including head and neck cancers and lung cancer. Really figuring out the best way to prevent cancer in this patient population is multifold, and we can talk about some of them, but directly to answer your question about cervical cancer and anal cancer, really, for people who are already infected with these viruses, HPV vaccines are unlikely to be effective. And so really the approach needs to be screening approaches. Cervical cancer screening programs, such as have been discussed, sometimes need to be tailored to people with HIV. In addition, we know that cervical cancer prevention decreases cervical cancer, screening programs prevent cervical cancer by probably 80% or more. In theory, we should be able to do the same thing with anal cancer. There's 80% of the cancers of anal cancers are probably preventable, and yet we don't really have a good screening program for them. The National Cancer Institute is conducting a study called the ANCHOR study, which is trying to take the concept of cervical cancer screening and applying it for anal cancer screening. So it's a long answer to your
No, that's great.
question.
That's great. So I'm thinking of the audience here, and that we have so many folks that are under the age of 18. And I'm wondering, I know you didn't provide this question, but I'm wondering if you could provide some advice on HPV prevention and some of the recommendations around vaccination and things like that.
Right. So really, the HPV vaccine, and there's a couple of HPV vaccines, but all of them target the two commonest. The HPV, there's probably 70 or more strains of the virus, and certain of them are high risk of causing cervical cancer and anal cancer and oropharyngeal cancer. Those are cancers of the tonsils. Are caused by a certain high-risk HPV, and 16 and 18 are the commonest ones. And there are several vaccines that target these strains of HPV. There are very effective vaccines that have been FDA approved for prevention of any HPV-associated cancer, and really the use of these should be before people become infected with HPV. And so the recommendations are to start vaccination with teenagers and extend into young adult and increasingly older patient population. So really the most important message is that really all adolescents should be vaccinated with HPV, and the uptake of this vaccine has been relatively slow. There are some controversies of whether it should be for just girls or girls and boys, but the recommendations are really quite broad, and I think the benefits will likely play out for all of these types of cancers.
Great, thank you. So those of you that are of the younger set maybe have something to investigate now in terms of personal cancer prevention. Thank you, Dr. Uldrick.
Sure.
I'd like to move on to Dr. Hirko, and I will tell you a little bit about her. She is an assistant professor in the Department of Epidemiology and Biostatistics in the College of Human Medicine at Michigan State University. Her research aims to understand the etiology of cancer through the investigation of modifiable lifestyle risk factors, particularly obesity and nutrition, to reduce the overall burden of cancer. She is interested in using biomarkers such as sex steroid concentrations and tumor marker characteristics to illuminate the pathways through which exposures to certain lifestyle factors may result in the development of breast cancer. So I have a few questions for her. And the disparities that she is particularly interested in talking about today have to do with disparities for our rural population. And so I'm wondering if you could talk a little bit about some of your research, and particularly that research around broadband access and the lack thereof.
Sure. So just to provide a little bit of background, I'm employed by Michigan State University, but I am a community-based researcher, so I am actually physically located in a rural part of northern Michigan in Traverse City. So I have done some research on racial disparities in my training, but now that I'm in a community that is rural, I've gotten interested in understanding some of the determinants of rural disparities. And one of those factors that has become apparent is the lack of broadband internet access in many rural parts of our country. So in urban areas, about 97% of adults have access to high-speed internet, but that drops to about 65% of Americans in rural areas, and it's even lower in our tribal communities. It's about 60% of adults having access to that. So, there's about 30 million Americans that are estimated to not have access to these services, and that really means that they can't reap all of the benefits of the digital age. And as we know, there are so many ways that broadband access can can impact health and the delivery of health care. So, for example, telehealth programs and mobile health programs have really incredible potential to reduce health disparities and kind of improve the healthcare access in the communities. But unfortunately, those communities who would stand to benefit most from those technologies are the ones, those are the rural and the underserved populations. Those are the ones that have are least likely to have access to those, the broadband internet that's necessary to deploy the technology. So I've been really interested in working on efforts to promote internet access as a social determinant of health. We know that internet access also leads to educational opportunities and employment opportunities, so it directly impacts the social determinants of health and should be considered actually as one of those social determinants of health and something that we can use to reduce rural cancer disparities.
So I have a follow-up question for
Sure.
you. Your team recently published a policy brief, and I'm wondering if you could summarize for us your recommendation on policy markers to reduce that digital divide you just discussed.
Sure. So I was part of a large national team that published a policy report to ensure that we can promote and protect the National Broadband Plan, which was enacted in 2010 to improve access to internet in rural communities and other communities around the country. So we, as part of that report, recommended to Congress to provide support for communities and how they can effectively implement the plan. We also asked for further funding. When you are trying to build infrastructure for internet to connect remote communities and geographically dispersed areas, it's a lot more expensive. So currently, the funds that were appropriated for this effort are probably not going to be sufficient to do that. And then finally, the third recommendation from that report was to address the fact that how rural communities that were appropriated these funds was decided based on a population estimate. So any community that was 20,000 people or less, according to the census, were prioritized. And our team felt that these efforts could be more targeted to communities that perhaps might not be at that cut point, that arbitrary cut point of 20,000, but perhaps there are communities where there are 22,000 residents, but they have a high cancer burden and low access to specialized care. And so we promote using existing public health data to really target those interventions and not just use that arbitrary cut point of communities that are 20,000 people or less.
Great. Thank you for highlighting something that I think a lot of people don't think about as a social determinant of health. And obviously, if we have all this amazing technology, but people don't have access to it, it doesn't necessarily achieve the results we want. So I thank you for that research. Okay, now a little bit of a transition. We are going to move on to talking with Sana Chehimi, am I saying that correctly?
Perfectly.
Oh, perfect. She is the Director of Policy and Advocacy at the Prevention Institute, and she leads their federal engagement and partnership outreach efforts by directing the organization's policy and advocacy portfolio aimed at supporting upstream prevention policies and investments to advance health, safety, well-being, and health equity. As part of the Health Systems Transformation Team, much of her work focuses on shifting perspectives on policy, strategic communications, and developing partnerships to promote community prevention practice. Oh, okay. All right. And so, Sana, I'm just wondering if you could tell us what it means to apply a public health approach to cancer prevention.
I would love to do that. How's everyone doing? Good? Or if you need to stand up, and stretch, or get the blood circulating, please feel free. I won't take it personally. We've heard the term risk factor a lot today, at least from the moment I stepped into the room. I've heard the term risk factor a lot. And taking a public health approach to cancer prevention means addressing those risk factors that are based in our communities. So that this is not, that go beyond our personal individual risk factors, but how do the places we live in, the places we learn, where we go to work, how do those communities either protect us from developing certain cancers or contribute to the likelihood that we may develop cancer? And so we heard earlier that risk factors for breast cancer, for instance, are our weight, our ability to exercise, how much alcohol we consume. And on one level, those may seem all like individual choices and behaviors, but if you take a step back, they're also really influenced by our community context. So we can't eat healthily if we don't have access to healthy, affordable, culturally appropriate food in our communities. And we may take it for granted that we can buy healthy food, but for many, many communities of color, low-income communities, being able to easily buy healthy food is not a reality. So that's an example of how that risk factor of being overweight is not entirely within that individual person's control. It's a public health issue. It's a community issue. Same thing with our ability to exercise. Can we move around freely and safely in our communities? Are there sidewalks? Are there safe parks and playgrounds? These are all public health implications that can impact our risk for cancer. Consumption of alcohol. Are we living in a community where there's a greater density of alcohol outlets? Are we living in an environment where we face toxic racism on a daily basis, where turning to alcohol might be a coping mechanism? These are all public health implications. And then there's the flip side, that what our communities look like and the decisions that are deliberately made about what's available in our communities can also have can be protective. So we can choose to invest in healthy food choices. We can choose to invest in active public transit. We can choose to make sure that there are bike lanes and safe sidewalks. We can reduce alcohol density. We can make sure that breastfeeding is supported. We can put in place workplace policies that allow everyone in a workplace to be able to breastfeed. So these are all examples of how we can kind of take a step back and look at how our communities are supporting us, or how our community conditions might actually be contributing to our risk of developing cancer over time.
Great. Yeah. I think it's really important to highlight that this is a public health issue, and there is much we can do individually, but there's even much more we can accomplish if we approach it on a community level. So I was going to ask you if you could tell us about some successful strategies. You've alluded to that a little bit. Do you have any specific examples that you'd like to share with us?
Sure. So the example that everyone, is probably thinking about is tobacco control, right? So once there started being links between use of tobacco products and increased risk of lung cancer and other cancers, the approach to that wasn't merely, well, we're going to tell people that they really need to quit smoking. It was also, we're going to ban smoking from airplanes this side of the room. It probably is unimaginable that there was ever a time when people could smoke on planes. I'm guessing that this side of the room has probably been on some of those flights where people smoked. I'm still not sure why they still have the ashtrays for gum, I guess. So clean indoor air policies, things like not allowing smoking in public places, in parks, not allowing smoking on beaches within a certain number of feet from a school. These are all comprehensive kind of public health policies and approaches that were put in place at the same time that there were treatment and cessation programs. We can take a similar approach with how we're ensuring that there is food access, how we're viewing active transit, as a public health issue, but also potentially as a protective factor for cancer prevention. So there are a lot of existing public health policies that are being championed that aren't necessarily being framed as part of a comprehensive approach to cancer prevention. That should be. We might have more collective success if we start framing some of those common public health approaches as also one of the tools that we have to prevent cancer.
Great, thank you. That was wonderfully phrased and a perfect example. So I would like to open it up to the audience now to see if anyone has any questions for any of our wonderful panelists. They're all doing pretty amazing work and just were able to tell you a small snapshot of that work. So any questions for any of them? Here's one.
Yeah. What are the limitations to having those federal like clinics and stuff? Like, why are there not more implemented in every?
Well, they're actually across the country. There are close to 1,400 federally qualified health centers, and that operate almost 12,000 sites. And some of those are in schools, and some are in public housing. So the limitation is that it needs to be in a quote medically underserved area. And then we, in addition to being open to everyone, we have a sliding fee scale. And so that's for people who are at or below 200% of the federal poverty level. We can offer them a discount on their services if they're uninsured or underinsured. And so it really is based on the demographics of that area. But with 12,000 sites across the country, 1,400 being run by 1,400 centers, there probably is a community health center, an FQHC, nearby where you are, wherever you are. And if you want to find that out, go to HRSA.gov, and they have a tool to look up your health centers. And if we want to talk about overcoming health disparities, I think health centers have been doing a great job for over 50 years, and they have strong bipartisan support for the work that we're doing at them. So that's really exciting. Great question.
That was a wonderful question. Thank you. Here's another one.
This is sort of for any of you, but when you're talking about disparities in healthcare, disparity that often comes up is race, and especially, I was just thinking with dark waters, and then Michigan obviously is a difference in the majority race population. So what can be done when you have something like that, where there's a big medical issue in a minority community that's not getting money or attention or like medical care that they need?
That is an awesome question. Who wants to be brave? And okay, Tom.
I can comment as it relates to HIV, which is something I understand best. HIV in the United States, in particular, disproportionately affects communities of color. And really, it's important to think of HIV prevention as cancer prevention and HIV treatment as cancer prevention. And so in the setting of HIV, there's been recently an increased push policy-wise from Secretary Azar to end HIV in the United States. That's by implementing goals of what's called 90-90-90. That means 90% of the people who are HIV infected know they're HIV infected, get enrolled in treatment, and are effectively controlled on antiretrovirals. That's done by measuring the virus in the blood to make sure that it's not detectable. And so the efforts to do that are through large organizations, through academic centers called the Center for AIDS Research, where monies are being spent to target specific communities, particularly communities of color that are at highest risk of getting HIV, and trying to implement prevention programs in those communities. So for the setting of HIV in the United States, that's one way that cancer prevention through HIV prevention is taking place.
Can also add, I mean, I think part of the approach is also rooted in being willing to name the problem and you know, name racism and discrimination as a leading driver to why there are inequities in health outcomes, and being willing to say that you know, health inequities they're not accidental. They're the result of very deliberate, both deliberate historical decisions, but also deliberate, like, present day decisions. Like, it was a very deliberate decision in Flint, Michigan that led to them deciding, now we're going to get the water from over here instead of, you know, over here, and we're not going to respond right away. And having people who are willing to call that out and name the underlying problem and not shy away from that is really important in order to actually develop comprehensive solutions that are going to address racial or health inequities.
One additional follow-up comment. I think that was just reminded, an important component of all the efforts has been to include the communities that are most affected. And so for the HIV prevention, for example, there are community advisory boards and community participation in all the efforts that go on. And that's really central to the success of any of the programs that are for HIV prevention.
So let's take this one step further, and Kelly, can you talk a little bit about rural? Because in Dark Waters, they're specifically talking about corporate, deliberate decisions by corporate that totally support an entire community economically, from employment and all of those kinds of things, but also can control and limit access to other things. So can you talk a little bit about some of the unique things about rural environments in terms of employment and how those things affect?
Yeah, and I will say, you know, with the Flint population, it definitely disproportionately affected the African American community, but it disproportionately affected people living in poverty. So it wasn't just, you know, a racially motivated decision necessarily. So there's, you know, it's tricky because when we talk about rural cancer disparities, often we think about mortality disparities, and it's most likely closely tied to those socioeconomic factors that we know are very important for health and health outcomes. And so it's often difficult to disentangle the role of socioeconomic status with the rural disparities. So some of the research that's looked at cancer rurality and cancer mortality, when they account for, in our models, when we account for the socioeconomic status factors, either those relationships are severely attenuated or, in fact, sometimes even disappear. So we know that socioeconomic factors are really important for some of these, but there are other factors as well. You know, educational programs that are built to raise awareness. This goes back to the broadband internet access. If you're not having access to that information, then you don't have the knowledge to be empowered. Another factor with rural communities is that they're disproportionately older. So the population age structure is significantly different, and that influences that as well. And there's factors that we don't know as well, but those are probably the main ones, I would say, is the age structure, the poverty factors, and the dissemination of information and lack of broadband access, how that impacts those communities.
So do we have time for one or two more
Sure.
questions?
We are going to be moving into lunch, and then Representative Byer should be here shortly, so
Okay.
it's going to be a little bit of a liquid experience, but
Okay.
sure, get some questions here.
Okay, so I'm not really sure how to word my question, but like I want to know if you guys have ever dealt with like LGBTQ discrimination in like healthcare and stuff like that, dealing with like cancer, and like the lack of LGBTQ healthcare. So this is kind of open for any of you guys.
So one of the things that, as a health center, that our mission is to ensure that no one's health gets left behind and to serve medically underserved populations. One of the things we've tried to do is think about what does that mean? Who is a medically underserved population? And in our community, which is a fairly rural community, that certainly includes the LGBTQ population. And so we've started doing direct outreach to that community. We're very proud to be part of, there's something called the Up North Pride Week, and every year, for the last 3 years, we've gone to the Up North Pride Picnic, which is over 5,000 people at the last time, to share information about our services, because we aren't just medical care, we are behavioral health services as well. And we're working hard to be designated as a healthcare provider of choice with our local LGBTQ community youth center. So that's something that's very important. We know that there are disparate health outcomes for the LGBTQ community. And so even in a rural setting, that is a community we have made a point of doing our outreach to.
I just want to add quickly that one thing that is impeding research in that area is that we're not really collecting that data in the health records. And so I know there's a lot of push now to collect that data so that we're able to have those conversations in the clinic, because we know there are disparate outcomes, but we have to be able to measure that in order to study it.
Thank you for your question. That's a very important question, and certainly the HIV community has been dealing with that in the United States. The LGBT community is disproportionately affected by HIV and continues to be the highest at-risk population. And cancers in this patient population remain an important problem. And so you cannot address HIV-associated cancers in the United States without addressing LGBTQ health.
Okay, thank you for that great question. I think that,
I think we're gonna wrap this panel up, and then we're gonna hear a little bit from Sana, but I also wanted to say, too, that while these people are great at identifying solutions, they are the same people, identifying problems, they are the same people. Thank you. They are the same people that create solutions for so many of these problems. And so while scientists and public health experts, they also are thinking creatively about bridging gaps. And I personally am super honored and grateful that you're here working on those efforts. So let's give them a big round of applause. If it's okay, I'd like to have you stay right where you are, and then can you tell us a little bit about your organization? You're going to get up and
Sure,
you
I'll
wanna
just
stay
do,
seated, or-
yeah, I'll just
Okay.
do like 2 minutes because I'm between you and lunch. So Bill very, very kindly said I could have an opportunity to just talk a little bit about Prevention Institute. Maybe you want to pursue a career in public health. We need more of you. So Prevention Institute, we're a national nonprofit. We've been around since 1997, and we're committed to health, safety, and well-being through thriving, equitable communities. And so our focus is very much on what can we do to prevent people from getting sick or injured in the first place. So as I mentioned earlier, how do we design and structure community environments that support health, safety, and well-being? What are all the things that can be done system-wide and structure-wide and policy-wide before people have to go into the doctor's office? And so we kind of work to shift the understanding of health as broader than health care. Access to quality, affordable health care is really, really important. And much of what determines our health is actually shaped by by where we live. We also work to shift the focus from one individual at a time to a population, so to entire communities. All of our work is rooted in health equity and racial justice, so really paying attention to what we do to prevent inequities in health outcomes, and to really put forth this message that prevention is possible. Cancer prevention is possible. Preventing violence, multiple forms of violence, is possible. Preventing type 2 diabetes, that a lot of the chronic conditions and illnesses that we kind of take for granted now in our modern day society, much of that could actually be prevented, and there are tools and resources available to do that. So I invite you to visit our website. It's Prevention Institute, all one very long word, .org. And all of our tools and frameworks are available free of charge. And if you're interested in anything, please feel free to reach out.